Hello everyone, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University with a joint faculty appointment at Ross University School of Medicine. And I wanted to here talk about pediatric asthma. And the StatPearls website for the National Library of Medicine is a great resource for many different things, statistical techniques, different subjects. It's good to go in and look at some of these. And the main objectives of pediatric asthma is that to identify the etiology of asthma, review the appropriate evaluation of asthma, outline the treatment and management options available for asthma, and then summarize interprofessional team strategies for improving care coordination and communication to advance asthma care and improve outcomes. So, as with many different chronic conditions, this also is a byproduct of inflammatory disease within the airways. So this causes some of the airflow to be obstructed, and there's development of not only bronchospasms, but also edema and increased mucus production. Commonly associated with seasonal allergies, allergic rhinitis triggers, eczema, atopic dermatitis. Allergic rhinitis, eczema, and increased mucus production. Some of these conditions are the atopic triad. So looking at the etiology, there's genetic, environmental factors which contribute to this. When I was seeing patients in Baltimore with asthma, one of the etiologies was that this teenager had recently moved from the living in the upper floors in the second floor of the house to the basement. And once he started living in the basement, this triggered the asthma, pre-existing asthma that he had. And so we suggested that he stop living in the basement and go back to living upstairs. So environmental exposures are critical not only in the prenatal stage, but also during childhood in the development of asthma. So one of the risk factors, incredibly important risk factors, is the prenatal period when maternal smoking can negatively affect the development. This appears to increase the risk of wheezing in childhood and likely increases risk for the development of asthma. Maternal diet and nutrition, stress, use of antibiotics, and delivery via C-section have been more increased with the exposure to asthma. So again, tobacco smoke exposure is detrimental to the developing fetus and even during the childhood stages. So the role of many other proposed risk factors remains unclear. So there's kind of factors that there's not much known about. I know about RSV being kind of associated with asthma, but not causation. So it might be like a trigger. According to the CDC, 8.4% or 6 million children in the US have asthma, and that's a significant amount. So there's asthma. Hospitalizations are actually higher in boys than girls. However, during the adolescent stage, girls more than boys. Severe asthma actually affects 5 to 15% of the population, and the reason the rates of asthma have gone up is due to increased urbanization. And 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 so this causes the increase in hospitalizations among historically marginalized populations. Um, so asthma involves the infiltration of inflammatory cells, neutrophils, eosinophils, and lymphocytes into the airway. And there's also activation of mast cells and damage to the epithelial cells. And this looks very similar to, especially, although in a more chronic manner, this looks very similar to COVID-19 and how this wreaked havoc within the body. Um, so cough, wheezing, chest tightness, shortness of breath, these are classic symptoms of asthma. Um, Upper respiratory tract infections, exercise exposure to allergens, tobacco smoke. These get worse at night. Reactive airway disease or wheezing associated with respiratory infections precede a formal diagnosis of asthma. Again, classic triad of asthma, eczema, and allergies to elicit a personal or family diagnosis. Um, Among physical exam, there's increased nasal secretion, mucosal swelling, or nasal polyps consistent with allergic rhinitis. And on the skin, there might be something called atopic dermatitis. Um, and so cough, prolonged expiratory phase, and wheezing. Uh, this is something that provides it may be expiratory or inspiratory. And when you're talking about either expiratory or inspiratory, there's common respiratory exam findings in asthmatic children and acute exacerbation. Um, Sometimes the signs are belly breathing, um, increased work for belly breathing, use of accessory muscles, especially not being just able to use the diaphragm. So they have to use accessory muscles, subcostal, intercostal, and supraclavicular retractions, nasal flaring, tripod positioning, inability to speak in full sentences, or grunting. Um, so if a child who has previously noted to have significantly increased work of breathing by caregivers, but who has now tired out, appears to be breathing at normal rate, becomes lethargic, impending respiratory failure. So that's a sign of asthma. Um, So altered mental status, lethargic, unresponsive, cyanotic, silent chest, has signs of impending respiratory failure and may rapidly decompensate to respiratory arrest. So I think we've gone over this, but more scientifically, if we look at children at least 5 years of age and adults, Um, pre and post bronchodilator spirometry can help confirm the diagnosis. Um, and so a lot of this takes place symptomatically, but if the baseline forced expiratory volume at 1 second over forced vital capacity um, is 25 to 75%, then assessment of the bronchodilator response begins with the baseline spirometry followed by the administration of a short-acting bronchodilator. So if you take 2 to 4 puffs, older children, adults, that does the trick, and greater than 12% improvement. So that's forced expiratory volume at 1 second divided by forced vital capacity. And there's some other tests, provocation tests, try to see if asthma develops. Exercise test. Exercise-induced asthma is something I have personally. Methacholine challenge allergy testing acute exacerbation. Um, so there's a step therapy for that will highlight this. It's proposed by EPR3. Um, and so a short beta agonist, a beta 2 agonist, this is step one. And then steps 2 through 6 refer to options for persistent asthma. So in each of these steps, inhaled corticosteroids are a component of the preferred treatment regimen. And then you add corticosteroids. Corticosteroids are there, and then montelukast, which is a leukotriene receptor antagonist in 4 milligram granules, or 4 and 5 chewable tablets, as well as 10 milligram tablet formulation. So long-acting beta agonist, leukotriene respiratory antagonist, and a combination with corticosteroid usage does the trick. And then there's acute exacerbations and supplemental oxygen, magnesium sulfate, corticosteroids. You can bring, but you want to prevent exacerbations. These are the staging, asthma severity and control. And here's some pictures. And as you can see, the airway in the muscle is much more pronounced. And there we have it, a presentation on asthma. Thank you for listening.